Okay, great. Well, let's get started. I'm going to mute my video, and I would ask that you all do the same, just because this presentation is quite video heavy, and we don't want the videos to compete with everyone's video feed. So if you could silence your video, that would be great. And also, if you can use a device that would handle video well, that would be ideal. Something like a computer or a tablet. I'm going to mute my video now. Can you guys see my screen? Okay,
Yes.
great. All right. Well, thank you all for joining this morning. I'm Andre Mansour. I'm an internal medicine doctor at OHSU. And this presentation is called The Art and Science of the Jugular Venous Pulse. It would not have been possible without Joe Nugent, a medical student here at OHSU, who created all of the videos that truly make this presentation unique. Nor would it have been possible without Peter Sullivan, who, along with Lynn Lorio, really ignited my interest in physical examination years ago and showed me how powerful it can be. The material in this presentation is part of a larger project that we've been working on for a number of years called Physical Diagnosis PDX. It's a website, and if you like what you see in this presentation, you will love the website. So let's begin with a quote from prominent heart failure physician Carl Lear, who has written extensively on the importance of physical examination. He writes, "The inability to properly assess the pressure level and wave contour of the internal jugular veins should encourage the cardiologist interested in heart failure to either learn and develop skill in this component of the physical examination or move to another area of cardiovascular medicine." And we love this quote. We couldn't agree with it more. And while he was addressing cardiologists, we believe this quote is even more applicable to general internal medicine clinicians. Our approach to the jugular venous pulse includes three separate but related components. The first component is simply identifying the jugular venous pulse, and then from there, performing a quantitative assessment and then a qualitative assessment. We'll talk about each of these components in some detail, and then we'll bring it all together at the end with a kind of a fun, interactive multimedia quiz. Section 1, identification of the jugular venous pulse. This is the single most important of the three components, simply because without it, components 2 and 3 cannot even be attempted. You will often hear from trainees and even other colleagues that the jugular venous pulse couldn't be visualized for X or Y reason, usually because of a large neck or the presence of a beard. In our experience, the jugular venous pulse is visible in the vast majority of patients. You just have to know where to look and how to find it. So where do we look for the pulse? The go-to place, the best spot for looking at the jugular venous pulse is the right internal jugular vein. It's ideal because of its direct route down into the right atrium. If you can't find the pulse on the right, then you should go next to the left internal jugular vein. And by the way, when we talk about the internal jugular veins, we're not actually visualizing the veins and the vessels themselves. We're visualizing the movement of the skin that overlies the vessels. That's an important point. If you can't find it on the right IJ, can't find it on the left IJ, then the third option that you should go to is an external jugular vein. And unlike the IJ, the EJ is visible in the neck, much like the veins in the back of your hand. If you've exhausted that list and you still can't find the pulse, don't stop there. There are other places to look, which we'll get into in a moment. Let's talk about the approach to identifying the jugular venous pulse. The first step, and perhaps the most important one, is patient positioning. Half the time I walk into a patient's room, they're sort of slouched in bed. They've got 4 pillows jammed behind their head. Their neck is sort of flexed against their chest. And if you try to move the back of the bed to change their angle, it simply just moves their head back and forth. That is not ideal, and you're not going to set yourself up for success in visualizing the jugular venous pulse. So what I usually do in that situation is I flatten the bed, and I help the patient scoot up so that their head is near the top edge of it. And now when I move the back of the bed, their neck and their torso move as one unit. And that's what you want. You want the neck and the torso to be in the same plane, meaning they're at the same angle. The neck isn't overly flexed, nor is it overly extended. You also want the neck to be nice and relaxed. You don't want the sternocleidomastoid muscles to be flexed in your way. And often this is a matter of either adding or removing a pillow to make that happen. And in my experience, it's most often a matter of removing a pillow. Next, after you've positioned the patient, you want to observe the neck. And it may seem sort of redundant or obvious to include observation as a separate step here, but we've done this to highlight how important it is. Because the tendency is to observe the neck from a perpendicular perspective. And if you do that, you're going to miss subtle and important movement. Imagine you're staring at a wall and you're 10 feet away. Well, you're looking at the wall from a perpendicular perspective. Now imagine you walk up to the wall and you put your right ear against it, and now you're looking down the wall. That's a tangential perspective, and that's how you want to observe the neck. Next, you want to locate movement, any movement. And the traditional window for viewing movement in the neck is between the patient's clavicle and the angle of their jaw. If the pulse is below the clavicle, you're not going to see it. If it's above the jaw, you may see it, but it's not ideal for evaluation. So you want to manipulate the patient's angle to either bring the pulse up from below the clavicle or down from above the jaw and into your viewing window. The final step, you're not done yet. After you've located movement, you're not done. You now have to decide, is that movement venous or is it in fact arterial? And there are a host of strategies for determining whether you're looking at a venous pulse or an arterial pulse. The waveform itself can be quite revealing. The arterial pulse has a single peak that is quick and sharp. The venous pulse is double and it's undulating in nature, meaning it has a soft rise and fall. The most striking feature of the arterial pulse is the outward movement. Obviously, what goes out must come back in, but it does so subtly and gradually, and it's hardly noticeable. It's a very passive retraction back to baseline. It's the outward movement that's active, and it's the outward movement that will catch your eye and that you will notice. The venous pulse, on the other hand, the exact opposite is true. The outward peaks of the venous pulse are passive. They're hardly noticeable. It's the inward movements that are active and will catch your eye, the X and Y troughs. And I put an asterisk there because that's probably, I think, the best strategy or the one that I use most often. If I see movement in the neck and I see an inward component, I'm done. I know that's venous. The breadth of movement can also be helpful. The arterial pulse tends to be pinpoint, involving a small area of the neck, whereas the venous pulse is diffuse, involving a larger area of the neck. The arterial pulse is unaffected by patient position, the respiratory cycle, and abdominal pressure. And the reason that's true is it's just an anatomical thing. So, you know, the reason we see the carotid and feel the carotid where we do, the reason we see the radial and feel it where we do, is because that's where those vessels course closest to the surface of the skin. And that is completely independent of patient position, respiratory cycle, and so forth. The venous pulse, on the other hand, will be affected by those things. In terms of patient position, imagine you've got a patient at 45 degrees and you see the venous pulse in the middle of their neck. Well, if you recline them back to a more supine position, that pulse is going to climb up the neck anatomically. If you do the opposite and sit them up, it's going to move down the neck. In terms of the respiratory cycle, when we take a breath in, we decrease our intrathoracic pressure, and that's going to cause the column of blood to suck down towards the heart. So the JVP typically moves down the neck with inspiration. Now, the opposite can happen, where you get a paradoxical rise in JVP with inspiration, and that's known as Kussmaul sign. We'll get into that later. But nonetheless, if there is appreciable movement in concert with the respiratory cycle, that argues for, and that is suggestive of a venous pulse. The venous pulse will move up the neck with abdominal pressure. And finally, the arterial pulse is palpable, whereas the venous pulse is almost always non-palpable with a few exceptions. Okay, now I want everybody to imagine that you're at the patient's bedside and recall the steps that we take when evaluating the neck. So the step one was position, and we've got the patient at 45 degrees. His neck and his torso are in the same plane. The neck is nice and relaxed, and we are evaluating the neck from a tangential perspective. And actually, let me 1 second here. I want to pull up the chat box. And by the way, we're going to save questions for the end, but let's see. But go ahead and fire questions into the chat box, and that way I have them for the end. Let's see here. Okay, so now we're at the bedside here. We have the patient in position. We're now observing the neck from a tangential perspective. And now the next step is to locate movement in the neck. And I think we can all agree that there is movement in the top third of the neck, right in here. Now our final step is to determine, is that venous or is it arterial? And if I were to describe this pulse, I would say this is a single outward peak that is quick and sharp. There's not really an active inward component here. It just goes out. That's what catches my eye. I hardly see it going back in. And it takes up it's involving a relatively small area of the neck. It's almost like you want to put your finger right there. And if you did, you would feel it. This is palpable. And these are all of the features of an arterial pulse. Joe has annotated the video for us. And so we can follow this cursor along the tracing and match it up with movement in the neck. And we can see where that pulse occurs. So here we go. Boom, boom, boom. I want you to think of this movement and then directly compare it to the movement in the following video. So here we have a double peak, a double trough. It's the troughs that catch our eye. Down, 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 or in. It's undulating. It's got a soft rise and fall. We don't really appreciate the peaks very well. It's really the inward movement that catch our eye. And look how diffuse it is. It's stretching. We can see movement from the bottom of the neck all the way to the top of the neck. Okay, so these are all of the features of a venous pulse. All right, so we mentioned abdominal pressure. So this is a physical exam maneuver where you put pressure on the patient's abdomen and you evaluate the effect on the jugular venous pulse. Now, it has several applications, but the one I want to focus on is how it can help you identify the jugular venous pulse, because we're still discussing the first component, identification of the jugular venous pulse. So what do I mean by that? Well, if I see a movement in the neck and I want to know, is that arterial or venous, and I put pressure on the patient's abdomen and that pulse moves up the neck, then I'm pretty confident that's a venous pulse. And here it is in action. So we've got the movement near the cursor here, and with abdominal pressure applied right about now, you'll see that movement climb up the neck, and now it's near the top, near the angle of the jaw. We mentioned the go-to places for evaluating the jugular venous pulse. Our first place was the right internal jugular vein. Sometimes that's unavailable, whether the patient has a catheter on that side or there's a thrombus there. Sometimes it's just not explained, and it's just not well seen on the right. Then you should go to the left IJ, as we mentioned. And this video is simply here to demonstrate the jugular venous pulse on the left side of the neck. So you can absolutely see it here and appreciate it. If neither of the IJs are available, what was our third option? Our third option was the EJ. And here's a beautiful example of the EJ in the neck. You can actually see it like the veins on the back of your hand. Here it is right here. And what I dislike about this video is that it's not filmed from the most attractive vantage point. We talked about the perpendicular not being your best experience. And if we were to, we can still see movement, which is great, but if we were to go to the tangential, you would have a much richer experience here. But what I do like about this video is it has an arterial pulse just next to a venous pulse here. So you can really appreciate the differences between them. So just to focus on the arterial pulse at first. Now this is probably an aneurysmal artery, so it's not totally normal, and it probably takes up a little bit more space in the neck than an arterial pulse typically does. But nonetheless, all the other features are classic for arterial. It's got a single peak that is quick and sharp. It doesn't really have an active inward component. It sort of passively tracks back to baseline. Now compare that to the venous pulse just next to it, where you have an undulating motion, you have a double peak, a double trough. It's the troughs that catch your eye. And look how diffuse it is. It stretches from the clavicle all the way up to the top of the neck. So back to our list. If you can't find it in the right IJ, you can't find it in the left IJ, you can't find an EJ to use, so you can't see it anywhere in the neck, don't stop there. Many clinicians would stop there and they would say the jugular venous pulse couldn't be visualized. And if you do that, you're going to get burned. And you're going to get burned because sometimes the central venous pressure is so high that even with a patient in the upright position, it fails to drop down below the angle of the jaw. And so there are some other places you must look. The periauricular area, the patient's temple, and their forehead are all classic places that the pulse can show up. And here's a great example of the unmistakable collapsing movement of the venous pulse in the periauricular area. If you don't see it in the neck and you don't see it in the periauricular area, look a little bit higher. Sometimes it shows up in the patient's temple. And here it is right here. You can see this collapsing motion in the patient's temple. If you don't see it there, look even higher. Sometimes it shows up in the forehead. In all three of these examples, the clinicians who evaluated the patient said that the jugular venous pulse could not be visualized, and that's because they simply failed to look higher. That concludes component number one, which is identification of the jugular venous pulse. And now we're prepared to discuss quantitative assessment. This is otherwise known as jugular venous pressure, or JVP. So we moved from jugular venous pulse, which is the umbrella term, to jugular venous pressure, which is a specific term. When a clinician reports a JVP of 8 centimeters of water or 16 centimeters of water, he or she is reporting a quantitative assessment. And we use this every single day in the hospital. So we should begin by asking the question, what are we measuring? We're measuring right atrial pressure. And in order to properly interpret a JVP, we have to be familiar with normal. When measured via a catheter in millimeters of mercury, normal pressure is less than 6. When measured via exam, In centimeters of water, it's less than 8. Why do we care about right atrial pressure? Well, it has tremendous diagnostic utility. When that undifferentiated patient comes in with dyspnea to the clinic or to the hospital, the JVP exam is absolutely critical, and at best will provide you with a diagnosis right there at the bedside for free. At worst, it will narrow your differential diagnosis. Beyond its diagnostic utility, we often use it to establish and follow volume status in patients who are admitted to the hospital with decompensated heart failure. And that's because of the relationship between volume and pressure. So now that we know what we are measuring and why we're measuring it, we're now ready to talk about how we measure it. So what we want to do is we want to measure the column of blood that's sitting above the right atrium. That's the manometer, and that'll tell us in centimeters of water the pressure of the right atrium. The problem is we can't see the right atrium because it sits in the middle of the chest. So we have to use landmarks that we can see to extrapolate to the right atrium. If we can figure out how high that meniscus is above a landmark, and we know how high that landmark is above the right atrium, well, then it's simple mathematics to decide how high that column is above the right atrium. The angle of Louis is one such landmark, where it's classically said to be 5 centimeters above the right atrium in any position. They did a study in 2002 that's in our references section, where they used CT imaging and trigonometry to determine the distance between the angle of Louis and the right atrium in various positions. And it turns out 5 centimeters is correct, but only in the supine position up to about 30 degrees. Beyond 30 degrees, it's more like 8 to 10 centimeters above the right atrium. The clavicles are another landmark that can be used, but only in the upright position, where they're 12 to 16 centimeters above the right atrium. So again, if we can figure out how high this column is above these landmarks, then it's a simple correction factor to determine what the JVP is, how high that column is above the right atrium. Now, textbooks love to use this image here, where they have a ruler, kind of a vertical ruler at the angle of Louis. They have another straight edge. There's multiple hands involved. It looks very cumbersome. I've personally never done this before, and there's a strategy that Pete taught me years ago, where you can measure the width of your hand. And that's what we do. So I know my hand is 8 centimeters wide, and now we can use our hand in the position of that ruler. So the hypothenar aspect of our hand, or the pinky side of our hand, is down on the patient's angle of Louis. The thumb is pointed up towards the ceiling, and now my palm is facing the patient's neck. Now I'll use my eyes and sort of visualize, where is that meniscus? If the top of it is near the top of my hand and the patient's in supine position, where the angle of Louis is 5 centimeters to the right atrium, well, my hand is 8, so I would say that's 8 centimeters plus 5 is 13 centimeters of water. If it's half of my hand, I would say, okay, 4 centimeters plus 5 is 9 centimeters of water. Maybe at the top of it, it goes above the top of my hand. So maybe I'll add a second hand, my left hand there. And I'll say, okay, it's a hand and a half. Well, for me, that's 12 centimeters plus 5 is 17 centimeters of water. And this is how we calculate the JVP at the bedside. This data comes from a 1973 study where they directly measured right atrial pressure and plotted it on the x-axis. And then they, at the same time, measured pressure within the right IJ, the left IJ, and the EJ, and they plotted those. What's that? They plotted those on the y-axis from left to right. And this data demonstrates a couple of things. Number one, the right IJ is highly reliable for estimating right atrial pressure. This is quite a linear relationship. The other thing that this demonstrates is that the left IJ and the EJ are nearly as reliable as the right IJ. So you should feel comfortable using any of these vessels to calculate JVP. Now let's put these ideas to practice. So here we have a video. We've got a woman at 45 degrees here, and we see movement in the neck. We're at a tangential angle. We see movement in the neck. We know it's venous because look at that inward component there. See how it sucks in? And look how diffuse it is. This movement goes all the way up to the angle of the jaw. So let's say we want to know how high what is her JVP? Well, to be honest with you, if I were at the bedside, because I'm not sure if the top of the column is truly here. It could be up here. We just don't know. To know that, I would sit the patient up a little bit and watch the column of blood kind of drop down into maybe the top or middle of the neck. And then I would be truly confident that I'm seeing the top of it. And then I would make my calculation based off of that. But just for the sake of this example, let's assume that the top of the column is right here at the angle of the jaw. So she's at 45 degrees, and the angle of Louis in that position is said to be 8 to 10 centimeters above the right atrium. She's a slender woman, so we'll go with 8. So if we can figure out how high this column is above the angle of Louis, we simply add 8 to it, and that's the JVP. And I will tell you that this is 12 centimeters above the angle of Louis, so we would say that's 12 plus 8 is 20 centimeters of water. And yes, the angle of Louis is sort of where the manubrium and sternum meet. There's sort of a change in angle there, and that's the angle of Louis. So anytime you see indentations in a patient's forehead, you should immediately consider long-standing central venous pressure. And this is a patient who has such a finding. And this is a gentleman that Pete and I saw together, and we were sort of at the bedside. We both sort of noticed these indentations at the same time. We kind of looked at each other, we nodded, and we reclined the patient back, and sure enough, those veins engorged with blood. And this is a gentleman with markedly elevated central venous pressure. Here's a similar patient that I've just evaluated the other day as part of the procedure service. We were asked to come and do a paracentesis on this patient. And I couldn't help myself. I mean, we're there for the procedure, but I couldn't help but notice these engorged veins in the patient's temple area. And in fact, when he turned his head, these veins were everywhere on his head. And here's the video that goes along with it. So you can see the veins here. Look at this EJ. It's like a hose there. You got the inward component here with the IJ. And he's in the upright position, by the way. When we span to the left, look in the temple area. There's movement right in here. There's movement. There's an inward movement. That's classic venous pulsation there. And so I asked his wife, I said, I couldn't help but notice these veins. Have you noticed them? And she said, yes, I have. I've noticed them for a couple, 2-3 months. And I've asked almost every clinician that this patient has seen about these veins. And not only were they unable to provide me with an answer as to what was causing them, but they seemed disinterested in the question. Well, we weren't disinterested. We were quite interested, and we asked the primary team to evaluate this and investigate this further. And he had a right heart cath done. And take a guess what his right atrial pressure was at this time. Now, he's in the upright position. Anybody have a guess? Yep, you guys are right on the money. 30 millimeters of mercury, which when you do the conversion multiplied by 1.36, turns out to be 40 centimeters of water. So this gentleman was walking around with markedly elevated central venous pressure for some months, and it simply wasn't recognized. And I think we've gone away from the fundamentals in medicine, and we're quite enthralled by technology, and we've sort of moved away. Our fundamental skills have atrophied. We'd like to see that come back. If you look in the neck, you look at the right IJ, you can't find the pulse. Left IJ, can't find it. You've looked at the EJ, you can't find one of those. You've looked in the periauricular area, the temple, the patient's forehead. You cannot find the pulse anywhere. There is one last place to look, one last refuge, and that is the patient's hand. We're going to let this video restart, but what you want to do is you want to start with the patient's hands at their side, and you want to evaluate whether they have visible veins on the dorsum of their hand. You can even look at yourself right now. Some of us have them, some of us don't. In this case, this video is going to start back over here in just one moment. This gentleman does have visible veins in the dorsum of his hand. So what we're going to do is we're going to lift the hand higher than the central venous pressure and allow those veins to collapse. So here we go. We're going to lift it up, and these veins are collapsing. They're gone. They're completely flat. You see how they're flat here? Now what we're going to do next is slowly lower the hand down until we find that moment where the veins begin to fill with blood again. And they are starting to fill. There they go. So it's filled here. So what we're going to do, watch what I do with my left hand. I'm going to extrapolate across, and I'm going to try to figure out how high that column is above the angle of Louis. He's supine, so his angle is 5 above his right atrium. And those veins begin to fill again at 20 centimeters above the angle of Louis. So his central venous pressure is about 25. That concludes components 1 and 2, identification of the jugular venous pulse and quantitative assessment of the jugular venous pulse. We are now ready to move into component number 3, which is qualitative assessment. Now, this is, and again, please feel free to fire off questions. We'll go back and try to answer these questions at the end. This is a bit more sophisticated of an endeavor where we're actually evaluating the waveform itself. But it's amazing how much you can learn about the heart by looking at the waveform. And to illustrate that point, I'll ask a question. What is Mobitz 1 heart block? I think we would all answer this question electrocardiographically. We would define it as PR prolongation before drop QRS complexes. And you would be right if you described it that way. But what if I told you that Wenckebach described Mobitz 1 several years before the EKG was available to him? How did he do it? Now, this is a talk on the jugular venous pulse, and if you're thinking just then that he must have used the neck veins, you'd be absolutely right. The question is, how did he use them? And hopefully, at the end of this component of the talk, I'm sorry? It'll become clear how he used the neck veins to accomplish this. Before we can talk about abnormal waveforms, we have to be intimately familiar with the normal waveform, each component of the normal waveform, and what cardiac events cause each component of the waveform. So let's start with the A wave, the first peak in the waveform. The A wave is caused by right atrial contraction. So obviously as the atrium contracts, that's going to generate an increased pressure within the atrium, and that's going to be a positive wave in the waveform. That's the A wave. That's going to be a peak. When does right atrial contraction occur? It occurs at the end of diastole when the atrium is trying to squeeze that last bit of blood into the right ventricle. And it's important to orient yourself early on to the cardiac cycle here. At least it is for me. It's very helpful because now I can sort of use that to my advantage, and I can go in order and just try to sort out, and it helps me remember the next components of the waveform and what causes them. So we're in late diastole. Now we're in early systole. And what happens in early systole? Well, we have isovolumetric contraction, where the ventricle doesn't quite mechanically contract yet, but the pressure builds up, and that's going to slam the tricuspid valve shut. And when the tricuspid valve slams shut, it bulges into the right atrium, and that causes a little pressure blip known as a C wave. Now, the C wave is not visible at the bedside. After early systole, we're in the middle of systole. And what's going to happen after isovolumetric contraction? Well, now you have actual mechanical contraction. And when the ventricle contracts, it squeezes and twists and contorts down towards the apex. And when it does that, it creates a mechanical event where it pulls the floor of the right atrium down towards the apex. And when that happens, it pulls the column of blood down. At the same time, the atrium has just contracted at the end of diastole, and now it needs to relax. So now the atrium is relaxing, and that's going to cause the pressure to go down. So the combination of right atrial relaxation and mechanical ventricular contraction causes the X descent. Now we're in late systole, and the atrium just relaxed. Why did it relax? Well, it relaxed because it needs to fill with blood again, so this whole thing can start back over. So when the RA begins to fill with blood, volume implies pressure, and as it's filling with blood, volume and pressure go up, and you get the V wave. Now we're done with systole. Now we're back in early diastole, and in early diastole, what's happening there? Well, the tricuspid valve springs open, and now you have passive ventricular filling from the right atrium. And obviously, as the right atrium loses that volume of blood, pressure will also go down, and that's going to create the Y descent. It is critical to have an intimate understanding of the normal jugular venous waveform and the cardiac events that cause each component of the waveform. Let's revisit this video from earlier in the talk, which is a normal jugular venous pulse. And many people will tell you that you can't visualize the individual components of the waveform at the bedside. It's a whiteboard phenomenon, and don't bother looking. Well, that's just simply not true. And this is a great example of that. So here we can see, and Joe has created this video where he's put the tracing over the top of the video, and you can follow that cursor along. And I think all of us can, at the very least, appreciate the descents. And again, that's what's going to catch your eye in the venous waveform, are the descents. So we've got X, Y, X, Y. And if I slow this down to quarter speed, here we go. So we've got A, X, V, Y, A, X, V, Y. So the descents will catch your eye. The peaks are somewhat passive, hard to notice, and but you can absolutely see the individual components of the waveform at the bedside. Here's another video with a trick using a Q-tip to demonstrate the individual components of the waveform, and Joe has annotated this for us as well. I cannot overemphasize how important it is in any part of the cardiac exam, whether it's cardiac auscultation or evaluating the jugular venous pulse, to understand where you are in the cardiac cycle. You want to know, because if you're looking at the waveform in a vacuum, it's hard to say, is that peak the A, is it the V, is that trough the X or the Y? So when I'm evaluating the waveform, you will often see me simultaneously palpating a pulse or listening to the heart, because I'm trying to find a frame of reference for myself so that I can correlate things with the waveform, and I can understand, is that the A or the V, or is that the X or the Y? And there is one cardiac event in particular that's very helpful to orient yourself, and that is S1. We know that S1 is associated with closure of the tricuspid valve. It's also going to occur at the same time as the peripheral pulse. And what component of the waveform is caused by tricuspid valve closure? Well, we just went over this. That's the C wave. Now, you don't see the C wave at the bedside, as we mentioned, but it's right in the middle of the X descent. So the X descent is going to occur at the same time as S1 and the peripheral pulse. So if you're looking at a trough and you want to say, and you can't tell, is that the X or the Y? You can feel the peripheral pulse, or you can listen to the heart. And if it's occurring concordant with those events, that is the X descent. If it's discordant with those events, that's the Y descent. Let's revisit this video from earlier in the talk where we have an arterial pulse and a venous pulse just side by side. And let's look at the venous pulse for a moment. There are two troughs here, but one is dominant. Right there. 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 What if I asked you, is that the X or the Y, and how could you tell? Well, if you had the benefit of being at the patient's bedside, you could do what we just talked about. You could feel the pulse, you could listen to the heart and correlate it. If it was concordant with S1 and the peripheral pulse, that's the X. If it was discordant, that's the Y. And we don't have the benefit of being at the bedside, but we do have this arterial pulse right here next to it. So if we can correlate this with the arterial pulse, we can tell. And if you look at it closely, that major descent, that dominant descent, is occurring at the exact same time as that arterial pulse. And so that tells us that that is the X descent. Okay, so now we are ready to talk about some abnormal waveforms. So here is the normal waveform, the top strip here, and that we're all familiar with. And the bottom waveform is abnormal. And so let's discuss what's abnormal about this waveform. So, well, we've lost our A wave. Okay, we have no A wave in this tracing, and our X descent is tiny. Remember, normally the X is more dominant than the Y. So we've lost our A, and we've mostly lost our X. And so we have to go back. We have to go back to what cardiac events cause the A wave, what event causes the X descent. For the A wave, it's right atrial contraction. The X descent is caused, at least in part, by atrial relaxation. So what condition is there an absence of coordinated atrial contraction and atrial relaxation? Well, that's atrial fibrillation. So this is a classic waveform of AFib, and it will also be irregular. That's another clue. And what you'll see at the bedside here is you'll simply see a Y descent. You don't really see the C, the X, the V, you just see a descent. Okay? The next abnormality that we're going to talk about is the giant A wave. So the A wave here is larger than normal. Okay, so again, what causes the A wave? Well, that's right atrial contraction. So what would cause the pressure to build up higher in the right atrium than it normally would? Well, that's going to be any resistance to RV filling, and that's going to occur as a result of tricuspid stenosis. It's going to occur as a result of elevated end diastolic pressure within the RV from something like pulmonary hypertension. Okay, so you're going to see at the bedside, you're going to see a peak that will catch your eye. And remember, that should automatically clue you into something is not right about this waveform, because normally I don't see the peaks very well. But if I see a peak, if it catches my eye, that tells me that something is abnormal about this waveform. After that peak, you're going to see two troughs. That's important. In the giant A wave, the subsequent X and Y troughs are preserved. Okay, that'll come up later. The other thing that's important is that the giant A wave occurs with every beat. That's also something to keep in mind. Okay. Let's move on to the next abnormality, which is the Cannon A wave. Now, this is larger than the giant A wave. It's more of like a shock or ripple up the neck. And so what's worse than contracting against a stenotic tricuspid valve? Well, it's contracting against a totally closed tricuspid valve, which can happen with atrioventricular dissociation. The atria and ventricles are kind of operating at their own rhythms, and every once in a while, the right atrium is going to contract against a closed tricuspid valve, and it creates, as you might imagine, this giant sort of shock-like wave up the neck, and that's a Cannon A wave. Cannon A waves, now again, the Cannon A wave is typically going to be intermittent, and in between the intermittent Cannon A's, you're going to see the normal waveform. There are certain circumstances in which it is occurring with every beat, but for the most part, it's going to be intermittent, and that can help you distinguish it from the giant A, for example. The next abnormality to discuss is a CV fusion wave. This is also known as Lancisi sign. And again, we have to go back to the normal waveform. What's going on here? So we've lost our X descent, and what has replaced it is a CV fusion wave. So we get this large outward wave here where the X descent would be, and then we get an augmented Y descent. And this is associated with tricuspid regurgitation, and it makes sense. The X descent is occurring with ventricular systole, and that's when the atrium is also trying to relax. So if instead of relaxing, it gets this giant regurgitant bolus of blood from the ventricle, that's going to create a huge positive pressure wave in the right atrium, and that's what you'll see. You'll see the CV fusion with an augmented Y descent. You may see at the bedside, what you're going to see is you may see a little bit of an A, but for the most part, you see one wave, one trough. Now, unlike the giant A wave, this is followed only by a single trough. You lose your X descent, and that can be very helpful in distinguishing the two of them, in addition to the fact that they're occurring at different parts of the cardiac cycle. So remember, knowing where you are in the cardiac cycle is really crucial. The A wave is going to be at the end of diastole. CV fusion is going to be right in the smack in the middle of systole. And that's what you'll see at the bedside. And again, it's occurring with every beat. The next abnormality to discuss is a sharp and deep Y descent known as Friedreich's sign. So what is the normal Y descent caused by? Well, that's an early diastolic event where you have passive ventricular filling. And the Friedreich's sign is associated with restrictive cardiomyopathy and constrictive pericarditis. So the way I think about this, and why is it sharp and deep? Well, the pericardium is sort of around the heart, and it's sort of unyielding, it's scarred down, and the ventricle can fill only so much before it runs into that unyielding pericardium. And so all the filling has to happen early in diastole before it runs into that pericardium. At least that's the way we sort of think about it. And that'll give you a sharp and deep Y descent. Some patients with constrictive pericarditis also develop a sharp and deep X descent in addition to the Y. And it's called the W sign because if you trace this out, it looks like a W. Why some subset of patients with constriction develop both a sharp and deep X and Y rather than just Friedreich's sign, unclear, but some of them do. And this is a finding that's more specific for constriction. The last tracing that I want to get to before we get to the quiz is Kussmaul's sign. Here you have a paradoxical rise in JVP with inspiration. And remember, when we take a breath in, we decrease our intrathoracic pressure. And not only is that column going to suck down towards the heart to cause the normal decrease in JVP with inspiration, but you're also bringing blood from the legs and elsewhere back to the mediastinum. And if there's an issue with RV compliance, if the RV can't accept that increase in blood flow from the legs and elsewhere, that blood has nowhere else to go but up the neck. And that's what causes Kussmaul's sign. It's not a very specific sign, but it's sensitive. It's sensitive to RV compliance issues from RV failure, tricuspid stenosis, constriction, restriction. So let's talk about, or let's move to the quiz mode of the talk here. And here we're going to show some videos of neck veins and try to figure out what is the qualitative abnormality that we're seeing. Before we start, I want to say a few things. First, assume the movement that you're seeing in the video is venous. That's first. The second thing is this will be challenging. It will be hard. And the reason it's so challenging in large part is because we don't have the benefit of being at the patient's bedside to do those strategies that we talked about earlier to understand where you are in the cardiac cycle. But, you know, when you look at these videos, I want you to think, what catches my eye here? Is it a peak? Is it a trough? If it's a peak, as we already mentioned, that should automatically suggest that something is not normal about this waveform. And then you're dealing with, is it a giant A? Is it a CV fusion? Is it a cannon A? You know, if it's occurring with every beat, that makes a cannon A wave less likely. So then you're dealing with a giant A versus CV fusion. Well, then from there you say, okay, how many troughs are there? Are there two troughs? In which case it's probably a giant A wave. If there's a single trough, that's CV fusion. The other thing that you should pay attention to is respiratory variation. So does the JVP vary with respiration? And also pay attention to whether the pulse is regular or irregular. Those things will help you. The last thing I'll mention is that there are some repeats. So just because we see a diagnosis once doesn't mean we won't see it again. So with having said that, let's move into our quiz and show some videos. So again, try to think, what catches my eye here about this video? Is it a peak? Is it a trough? What am I seeing? And I'm just going to kind of talk through this. You guys can feel free to type in the answers as you think of them. And I'm just going to talk through it. So what I see is I see a single outward peak, and that definitely catches my eye. And so I know automatically that this is not a normal jugular venous pulse because the peaks aren't so conspicuous normally. They're hard to see. And Sahan is exactly right. This is CV fusion. So when we think about this, we say, okay, there's a peak that catches my eye. So I know I'm dealing with a giant A, CV fusion, or cannon A. Well, it's happening with every beat. That makes cannon A less likely. And plus, it's not a shock like. It's sort of more of a rolling kind of wave up the neck. And that's not exactly how a cannon A wave looks. So now I'm dealing with a giant A or CV fusion. And the next question we want to ask ourselves is there one trough or two following this wave? And I see one single trough. And so this is consistent with CV fusion. This is a gentleman with severe tricuspid regurgitation from dilated cardiomyopathy. And here's the annotated video that Joe has made for us showing the CV fusion and the big Y. Look at that Y descent. Let's move to the next video here. Feel free to type in your answer as you see it. So as we observe this neck, what do we notice? Is there some kind of respiratory variation? So here's the annotated video. You can see the JVP in the middle of the neck. As the patient takes a breath in, yeah, Bruno, that's right, it's Kussmaul's sign. So as she takes a breath in, there it goes, all the way up the neck to the angle of the jaw. Look at that EJ fill. It's like a worm in the neck. And this is Kussmaul's sign. This patient also has another finding as well. So if you look at those X and Y descents, they look rather sharp and deep. She has a W sign as well. And this is a patient with constrictive pericarditis. She actually developed it. It's a rare sequelum after orthotopic heart transplantation. And so she developed constriction 20 years after that procedure. Let's look at the next video here. And again, think to yourself, what catches your eye here? Is it a peak or is it a trough? What catches my eye is a trough. I see a trough right there, there, there. There are several troughs, but one in particular is quite larger than the other. And so I want to know, is that the X or the Y? Now, if we were at the bedside, we could utilize those strategies we discussed and feel the pulse, listen to the heart at the same time, and try to decide, is that concordant with those events, in which case it would be an X descent, or is it discordant with those events, in which case it would be a Y descent? And I can tell you that this large descent here is discordant with the pulse and with S1. It is consistent with a Y descent. This is Friedrich's sign. So there you go. You see a little bit of an X and then a big Y. So here we go. So a little X, Y, X, Y, X, Y. And this is a gentleman who came in with tamponade and developed a phenomenon called transient or subacute constrictive pericarditis, which I wasn't familiar with before this case. I always thought that constriction was a permanent thing, but it can be subacute and transient. And his findings of constriction disappeared after a few weeks. So let's move on to the next video here and ask yourself, in this video, what is catching my eye? Is it a peak or a trough? What do you guys think? What do you notice here? Peak or a trough? What catches your eye? Yep, absolutely, Bruno. There's a peak here that catches your eye, and that should immediately make you think that something is not quite right about this waveform, because the peaks in the normal jugular venous pulse are not conspicuous like this. So we see a peak, and so then we're back to our sort of differential. Is it a giant A? Is it a canon A? Is it CV fusion? And how many troughs do you see? So it's occurring with every beat, so less likely to be a canon A. So we're thinking giant A or CV fusion. How many troughs do you see following that peak? Yep, 2 troughs, exactly, Jorge. So this is a giant A wave in a young woman who developed pulmonary hypertension as a result of methamphetamine use. So here we go. So we can really see it. We can follow that tracing along. So here we go. A, X, V, Y, A, X, V, Y, A, X, V, Y. That's quite an impressive A wave. Let's move to the next video here. So what do you notice? Anyone know what this is? Is there some respiratory variation here? So there's the JVP, and when he takes a breath in, look at it climb all the way up the neck to the angle of the jaw. This is Kussmaul's sign. What else do you notice about this gentleman's skin? What is this mark right here, right below the A wave in our logo? Anybody know what that is? That circular mark there? Yes, Mohammed, that's exactly right. This is a radiation tattoo. And how can you put that together with Kussmaul's sign? Well, this gentleman had Hodgkin's lymphoma when he was a teenager, had radiation to the chest, and that led to constrictive pericarditis. Great job. All right, let's look at the next video. This is perhaps my favorite video. So what do we notice here? There's clearly a peak that we can all see. And there's clearly, then the next question is are there 2 troughs or 1? There is 1. This is an augmented Y descent following CV fusion, and a gentleman with severe TR, which was an iatrogenic complication, actually had a catheter that damaged his tricuspid valve and causing severe TR. Okay, so for this next video, I'm going to put the annotation on because it's very difficult to tell where she is in the respiratory cycle. We did not talk about this during the talk, but here we see the JVP way up there with expiration and way down here with inspiration. And you might be thinking, well, that's normal. The JVP should go down with inspiration. You'd be right, but not quite to this degree. This is marked respiratory variation. This is very dramatic. It should go down maybe a couple centimeters, but to go down, this is going down at least 12 centimeters here. This is marked. Anybody know what condition is associated with marked respiratory variation in the JVP, where you get a pseudo elevation during expiration or exhalation? Anybody know what condition? Pulsus paradoxus. That's a good guess, because you can get pulsus paradoxus for the same reason from lung conditions like asthma. And this is somebody with lung disease. And the reason is because during exhalation, they generate quite elevated intrathoracic pressure, and that's going to drive the JVP up. And when they take a breath in, they create really large negative intrapleural pressures, and that pulls the JVP down. So you can I put this in here because it's important. You can get fooled by the pseudo elevation and think that this person has a markedly elevated JVP. She's in the upright position, and I've been fooled by this in the past. So I figured it was high yield to put in here. What is this? What do we see here in this neck? So what I notice here is I see just a trough. Boom, 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 boom. I don't really see a peak very well. I just see a single trough, and it's not really happening in a regular rhythm. This is irregular. I just see a Y descent. This is a classic AFib. We've lost our A. We don't really see the CXV at the top. We just see a Y descent. And again, it's irregular. Sometimes you can get fooled. Sometimes when the beats are close together, you might think this is an X followed by a Y, but in fact, it's two Ys that are close together. So this is classic AFib. What do we think about this video? What do you notice here? Anybody know? Jorge, I know you know. You got it, Mohammed. This is Kussmaul's sign. So another example of Kussmaul's. Look when she takes a breath in, how these veins engorge near the angle of the jaw. Look at this one. What do you guys think this is? It's another case of one single dramatic wave followed by one single dramatic descent. This is another case of CV fusion. You got it, Mohammed and Sahan. Nice job. This is severe TR causing CV fusion. I have never seen the facial vein involved before this patient, and I have not seen it since, but here it is. And we're almost getting to the end here. This is a tough one. What do you notice when you look at the movement in this video? What catches your eye here? Is it a peak or a trough? To me, I see a peak that's a little bit more impressive than normal. It's a little bit more conspicuous. And this is a giant A wave where you have the big A, so A, X, V, Y, A, X, V, Y, A, X, V, Y. So this is a young man with tricuspid stenosis who developed giant A waves as a result of that. And here they are. So look at that A. It's really impressive. Boom, down, V, Y, A, X, V, Y. And this is another example of Kussmaul's sign here, where the patient takes a breath in. You can really see it rise. And this is just with tidal breathing. It's quite impressive. These signs are all over the place. We see them all the time. I was told once that I would never see Kussmaul's sign, or hardly ever. You might see it once in your career. I see it once a week. We see this stuff all the time. You just have to take the time to look for it. And this is a great example of Kussmaul's sign here. Okay, this is the last video. What do you guys notice here? So what I see is a ripple up the neck that's occurring intermittently. See it there? So right there, right there. And this is a Canon A wave in a gentleman with complete heart block. So you can see the normal waveform down here in between, but then every once in a while you see this ripple that goes up the neck. So there it is, normal, normal. There it is. There it is. This is AV dissociation. Okay, last video. We've got Russell Crowe from one of my favorite movies, Gladiator. By the way, Maximus is not supposed to be alive at this point, but clearly we can see movement in his neck. So Russell Crowe is a great actor, but he's not that great. And so the question is, do we think that this is venous or arterial, and why? And this is clearly a venous pulse. Look how diffuse it is. We have movement involving the entire neck. There's clear inward movement, and this is a venous pulse. Before we conclude, let's bring it back to Wenckebach. So how did he describe Mobitz 1 using the neck veins? Well, let's go back to the EKG. What is the equivalent of the P? What is the P wave on the EKG? Well, that is atrial depolarization / contraction. And what is that in the neck veins? Well, that's the A wave. How about the R? That is ventricular depolarization / contraction. And what is that in the neck veins? That's the X descent. So he observed AX prolongation leading up to dropped arterial pulses. Quite remarkable, but it is incredible how much we can learn and know about the heart by looking at the waveform itself. That concludes our talk. Thank you guys for being here. For more of this stuff, if you like what you saw, we have our website coming out, and then we also do a lot of physical diagnosis stuff on social media, so you can check us out there. And here are the references for our talk. It looks like we have about 5 minutes or so. I'm sorry.
Andre, it's Stephanie, and I was wondering if you would like me to help moderate some of the questions since we have a few minutes.
That would be great. Thank you, Stephanie.
And my apologies for missing the opportunity to introduce you at the beginning. For those who saw it, I did put Andre's intro in the chat, and thank you for a wonderful talk. There was a question early on just about a refresher about where the angle of Louis is and what that represents.
So that's where the manubrium and the sternum meet, and there's kind of a little bit of a bulge there. It sort of changes angle, and it's a couple centimeters below the sternal notch, and that's the angle of Louis.
Great. And then there was a question about your thoughts on use of ultrasound in evaluating the JVP.
You know, I think that there is some utility in it. I personally have never been at the bedside and thought to myself that I need an ultrasound. Certainly to evaluate the JVP. For other things like procedures, looking for fluid pockets and things like that, I find great utility in the ultrasound. But for neck veins, I just haven't found myself in a situation where I thought to myself, "Gosh, I really need an ultrasound here." I think if with enough time, effort, and training, that physical exam is all you really need for this.
And to that end, somebody asked, "Do you have any strategies for getting feedback on JVP assessments in order to improve?"
I absolutely do. So I mentioned Pete Sullivan a few times during this talk. What he represented for me is what I would encourage everyone to do who's learning physical examination, is to find somebody that you can corroborate findings with. So Pete and I still, to this day, 2 weeks ago, there's a finding and I'll call him, he'll call me, we'll go to the bedside, he'll keep the finding from me, and I'll listen to the heart and I'll tell him, okay, I think that there's an S3 here, I think there's a pericardial knock, or whatever it is, and we will do that consistently throughout the year. And having that feedback is really, really critical, because again, this is something that if you just find yourself at the bedside, I think that's what I see, but I'm not sure, it's going to be tough for you to kind of gain traction. But if you have that partner who can sort of confirm or deny, in some cases we don't agree, what there might be, that's very helpful. So that would be my advice.
Great. And then there was a question about the correlation of hand vein measurements to directly measured central venous pressure.
Yes.
You did put a reference in the chat, but I don't know if you have anything to add to that.
Not really. I think there was one study. Pete and I were going to do this study when this one came out. It's called the Anthem sign, or at least that's what they coined it. And they did correlate it with, I don't think they got the exact, and by the way, this is not an exact science. We're not going to say that the JVP here is 17.2 centimeters. It's really more about, elevated, normal, low. And that's what they found in that study, was the hand veins did correlate with bigger sort of buckets, elevated, euvolemic, low.
And to that end, somebody mentioned they often see prominent forehead veins in elderly patients. And do you know if that could just be a normal sign of aging, or should we be concerned about elevated jugular venous pressure in those patients too, or central venous pressure? That's
a great question. I'm trying to think now. I'm not sure what they're exactly referring to with the dilated veins in elderly patients. I would have to actually see the patient myself to know what you're referring to. But I would say that if you're seeing that often and you don't think it's a result of elevated central venous pressure, go ahead and look for the JVP. If you see it below, clearly below, then I would say that those veins are probably dilated. Maybe just from valvular dysfunction within the veins or things like that. But if in some cases it should make you think elevated central venous pressure. Stephanie, I think you're muted. I can't hear you.
You'd think by now I would have that figured out. There are actually several other questions and lots of very nice comments, Andre, that I hope you get a chance to read. But maybe for the last question, can you comment on how often you've been able to use these signs to actually diagnose pathology versus observing them after the diagnoses have been made?
So I'm glad somebody asked.
You did say it's a loaded question.
I'm very glad that question was asked, because I think that is something that you can use in addition to having a buddy. I call Pete the gold standard. I'll use him as my barometer when I'm evaluating somebody. But if you do have the benefit, especially when you're first starting off training, you have an echocardiogram that shows severe aortic regurgitation, you should absolutely go to the bedside and kind of correlate it with your exam to kind of to calibrate your exam. And am I hearing that decrescendo diastolic murmur? Am I seeing Corrigan's pulse in the neck? Am I seeing water hammer pulse or feeling water hammer pulse? You should look for these things after the fact. That will help you get better. And then to address the first part of the question, absolutely. I mean, this stuff happens all the time. Just a couple weeks ago, I showed that example of the gentleman with the dilated veins up to the head, and he was walking around with a RA pressure of 40 centimeters of water for months, and that diagnosis had not been made. So this happens quite frequently. And again, I think we just need to get back to the fundamentals and back to the basics. And Stephanie, we had a couple hitches in the beginning, so that delayed our talk. I'm happy for that reason to stick around and answer some additional questions beyond 9 o'clock. I'm at home, as you can see, so I have nothing to do. I'll hang out all day. And you're muted again, Stephanie.
Thank you to you and to Joe, who I didn't get a chance to introduce, but the MD-MPH student who's been working with you and is responsible for some of the amazing technology that really brings these images to life. For those who can stay for a few minutes, please do. And for those who have to go, thank you for joining us. Andre, there was one question about how you go about getting patient consent and handling patient privacy with the sharing of videos, especially since you use social media to teach.
Yes, great question. I would say this is institution dependent, and you should work with the patient privacy office to ensure, at whatever institution you're at, to ensure that you're following the proper protocol. In our case, we obviously have an informed consent process with the patient, and we tell them, this is going to be used for educational purposes. And it's amazing. I mean, I would say 99% of patients, if not more than that, are so happy to provide their images for educational purposes. And, we've been doing this for many years. This is really no different than the images that we see in textbooks. Patients have been educating doctors for, many, many years. And that's no different in this case. But you do have to go through the proper channels and make sure that you obtain consent in the correct way, and the patients understand what they're getting into.
There was maybe one more question that I saw, and it was about, do you use a flashlight? If so, when?
I hardly ever do that. Not to say that it can't help, and maybe in certain circumstances it does. I like natural lighting when I'm evaluating the jugular venous pulse, and I tend to, again, use that tangential perspective. And when you do that, it's amazing the subtle movements that you'll be able to pick up. Again, the tendency is to look at the neck from a perpendicular, but when you do that, you're going to miss those subtle movements. So going from a tangential vantage point can be very helpful in picking up subtle movement. And again, I like natural light, but again, if the flashlight helps you, then by all means use it.
I think I've captured most of the questions there. And my apologies if I've missed any.